Thank you very much. The objective of this presentation is to balance what has been talked about in the two previous presentations. These were really very pessimistic pictures that emerged. What can we do in our practice? There's an addict who cannot use judgment anymore. What's important? What takes priority? The skills to identify that has been greatly reduced. So how can we direct them to remain sober and to stay away from the substance? So in light of all this data, and in spite of this data, I'll try to address this. Yes, it has been explained just now, so I won't belabor on it, but we know that in our brain there is this rewarding pathway. Take BTA, nucleus accumbens, prefrontal cortex, dopaminergic, neopioid neuron containing system. And this system is in fact, this is a system that ensures the propagation of the species, including us. We take pleasure from food, water, and sex. And when that satisfaction is fulfilled, we derive pleasure. This is why we do these things. We eat not because our protein levels drop. We eat because we want the food. We crave the food. In all species, this is present. Dopaminergic receptors are there. And not only dopamine receptors, these are very complicated interactions here. At the same time, there are opiate receptors, MMDA, etc., etc. And dopamine, and with dopamine reuptake pump, it's taken back. And all of the addiction-creating substances, their common characteristic is that they have an impact on the system in the brain. As I said just now, various receptors there over them and over different mechanisms, they increase dopaminergic conduction and they cause an excessive hyperactivity. For instance, morphine stimulates the opiate receptor, increasing dopaminergic release. Normally endorphin is, let's say, if it's going to be stimulating that in one severity, morphine does it 1,000-fold, and the conduction increases. Or cocaine prevents the dopamine reuptake pump. It competes with the dopamine and it makes sure that dopamine remains longer in the synaptic interval. So this can be explained for all substances. Of course, the only impact of substances does not constitute of that. For instance, opiates in the brain and in the spinal cord, they have locations that you can see on with these green markings, and parallel to this distribution, they may have a different effect. So the midbrain activity impact that we're talking about just now. As has been talked about in the two previous presentations, substances have a direct relationship with pleasure. So the basic mechanism of existence is used. That's why probably dependence, addiction does not have a permanent cure. Probably it will never be found, because the mechanism that causes this dependency, when we eliminate them in the brain, the person maybe will be a vegetable and will no longer be a human being. So that's the challenge. Yes, the first two speeches, technically, they were very comprehensive technically, but the pleasure derived from these substances and the value on the part of the dependent is increased. And in spite of the negative things that happen to the individual, they will continue to use it again and again. And now we call this the dependency, the addiction paradox, dilemma. On one side is pleasure, on one side of the scale is the damage. Sometimes in some individuals this judgment can be so disrupted that, for instance, there are cirrhotic changes in the liver, and in spite of that, or in spite of the presence of cirrhosis in the liver, they may continue to use alcohol. Or if there's a serious problem in the lungs, they may continue to smoke. However, these are a bit more extreme examples, I could say. In fact, in many patients, when there's sufficient harm, then they may stay away from substance. I don't know if it's correct, but I had listened to something like they had taken a frog and dropped it in boiling water, and the frog will jump and get out of the pot, out of that boiling water. I don't know. I never tried this. I'm sure none of you have, but that's what is said. However, if you put that frog in the pot and put it on the stove with the water, and then if the water starts boiling little by little, the frog dies in the boiling water without feeling the need to jump, to leap out of the pot. So maybe family members should get the following message, because what the families do is just the contrary. They try to prevent the individual from feeling the pain. They don't want them to be demoralized. They want to do all kinds of sacrificial stuff for them. They go to the police, they bribe, and they say they go talk to the manager at the office or talk to teacher in school to make sure they succeed, thinking that the individual will no longer do these mistakes. Whereas the person is not in a position to be able to understand and evaluate this. The state of mind is little by little distancing itself from this fact, and this reward and punishment system distances that individual from the otherwise normal individual. The treatment of addiction, the basic principles in psychopharmacology Congress especially, this has to be emphasized, I think. Addiction cannot be treated like infection being treated with antibiotic. Of course, dopaminergic mechanisms, etc., help us in understanding addiction. Yes, addiction is a disease, but addiction, for instance, depression can be treated with antidepressant without having to add psychotherapy. Just giving antidepressant solves cures more than half of the depressive patients, but as you know, pharmaceutical trials in the area of addiction, they also necessitate psychosocial approach. It's routine in both groups, meaning addiction cannot be resolved by standard pharmaceutical therapy. And we should not be forgetting drug treatment in addiction are not magic wands. They're just sticks, canes. Somebody who has difficulty in walking may benefit from a cane for walking, but if they take the cane and put it on their laps, they'll never walk. So drug treatment in addiction is like this. If the individual has the intent of walking, the cane may help, but it does not make the individual walk. For instance, this trial may help. This has been conducted in the area of smoking. Many outcomes of many studies are being assessed. Without quitting smoking without any help constitute 2-3% of the entire population. When there's nicotine replacement treatment, likelihood of success, for instance, they go and they buy a nicotine patch or nicotine gum from the pharmacy. These are people who treat themselves, and if the physician gives, it's the way they say, use it like this, use it like that for such and such period of time. In these people, the likelihood of success increases by 2-fold without any pharmacological support. Just by providing consultancy, likelihood of success is increased by 5-fold. Both nicotine replacement and consultancy cost tenfold increase in the likelihood of success. Even if this has not been studied exactly like this, in all addictions and in all drug treatment, the basic principle can be observed to be just this. In ambulatory treatment of addiction, of course there are challenges, particularly in our country. Teamwork is generally not possible apart from large clinics like Amatem. Many psychiatrists do not collaborate with a psychologist or a social worker or an experienced nurse. We don't have such therapeutic teams, unfortunately, and they are by themselves, and most of the time they can't allocate much time for these patients, and that's how they have to treat those patients. On the other hand, the patients, their adherence to treatment is low, and of course it makes it difficult to follow those patients between visits. So these are one of the biggest challenges in the field of ambulatory treatment. And to be able to succeed in this, the family members and the close environment should be included in the therapeutic process. It's one of the most important and beneficial factors. Therefore, for this, Galanter is presenting an approach model called Galanter. This is different from family therapy. And before the details, including the family in the treatment process, let's see where this is important. Because, for instance, dynamically oriented colleagues say that at the basis of this addiction there is the psychodynamic conflict within the individual. First we have to solve that, and they will then discontinue the substance. Anyway, they still think. These are wrong in the light of scientific data. Trying to treat the individual by themselves can only be because they have no other choice, but if there's family, they have to be included both in the history-taking process and in the administration of medications, detoxification, if it's ambulatory, etc., etc. There are a variety of points where the family may help us. In network therapy, the focus is the sick individual as opposed to family therapies. In family therapies, you know, interfamilial dynamics should be solved, conflicts should be solved. That's the objective of therapy. Here, it's the addicted individual and preventing him from using the substance. That's the main objective. People who are going to be included in the therapy, we select them with the patient. Interpersonal dynamics are kept in mind when doing this, especially people with no history of substance abuse or alcohol abuse. Social environment, the family, integrating them into the treatment process, and even finding such a family or group of friends is not always so easy. In the early stages of substance use, there's serious denial on the part of the patient, so therefore it is themselves who try to keep those people distant. I'm sure this is something our colleagues who work in this field encounter. I don't want my family to hear. I will receive treatment, but I don't want my family to hear of this. Let's do this without letting them know. These are the approaches on the part of the patients. And in the more advanced stages, the family, the social environment, etc., they're already lost by the time we encounter the individual. Therefore, this may be quite a challenge. My personal approach is to definitely involve the family and the group of friends. If the individual is above 18 years of age, and if they have IV and heroin use kind of problems, or if they have suicidal ideations, of course we cannot inform the family of this. It's not ethically correct, but even there, the person, we direct the person to share this problem with the family, in order for the individual to receive direct help from the family. And in the more during our meetings, I try to convince the patient to do this. A most striking example is a cannabis addict university student did not want the family to learn because of he had told the family that he was receiving treatment for depression, and I had promised not to tell the family, so I did not. In spite of different attempts, this person could not stop using the substance, but there was motivation to stop on the one hand. And within that therapeutic collaboration, yes, after a certain point, we had to bring in the family as a support system, and he accepted this, and we explained this to the family. Of course, up until now, the family was not aware, and after that, there was serious increase in therapeutic success. Medication treatment is integrated, can be integrated in the system. Ambulatory detoxification, if that's what we're going to be doing, these are the contraindications. I'm skipping them now. The family, again, has to be brought into play here. In alcohol-dependent patients, the only benzodiazepine, a single dose benzodiazepine, long-acting benzodiazepine, can ensure detoxification, or we may have daily observations of 3 to 5 days. Last 2 minutes, particularly in ambulatory detoxification, the family, for instance, benzodiazepine should be administered by the family. They should be the ones who have it. And in case the patient's in the event the patient takes alcohol, benzodiazepine should not be given, and disulfiram should be given in a controlled manner. The family may help us. Disulfiram, when it is given without observation, we know that it does not have an effect. They talked about cocaine addicts just now. He said disulfiram may have a direct effect on them. Apart from that, disulfiram benefits cocaine addicts because it acts over the mechanism of alcohol use, because the most significant triggering effect for cocaine users is alcohol. If they have taken little alcohol, then they start seeking cocaine, or else they abuse the alcohol, which may lead to alcoholism. However, neither alcohol addicts nor cocaine addicts can keep this up for long periods of time. Again, we may ask for the family. There are some subcutaneous medications, especially in opiate dependence. This may help. And factors which include the likelihood of therapeutic success. Of course, we should not be forgetting support groups, and thank you.